I want to invite to the stage our executive keynote panel members: Peter Adler, President and CEO of Molina Healthcare of Washington; Daryll DeWald, the Chancellor of Wazoo Spokane School of Health Sciences; and Russ Myers, the CEO of Virginia Mason Memorial Hospital. Let's give them a round of applause and have them come to the stage. Gentlemen, go ahead and pull up a chair. Hopefully those microphones are all turned on and working. Peter, let me just ask you first to respond. What did you hear that stood out to you in Kathy's remarks?
You know, I need to be honest here. I'm not a politician. I think the rhetoric and the headlines are all the right things to say. Yet I know in the polarized environment, and I look at the votes, the voting record, and the audio and the video, for me, often don't match. Not just with what we heard, but often from a number of our elected officials.
Mm-hmm. Daryll, how about you? What stood out one way or the other to you in those comments?
I also am not a politician, so I can lean on that. But the one thing that we would like to achieve, I guess, in what the Congresswoman was saying, is to really begin to develop more partnerships to solve problems instead of trying to do this independently. Mm-hmm. So I do buy into that message very much.
Russ, same question?
So I like where you're going, partnerships. You know, I think we can all be and must be tuned in to public policy and the debates around public policy and the conflicts around public policy, and clearly they have impacts on us. But I guess the one comment I would make is we all have plenty of work to do without that. We have work to do within our own organizations to improve the quality of the product that we're working on, and I think it does take partnerships to be a part of that.
Russ, let me ask you sort of a follow-up question. By the way, anytime somebody says I'm not a politician, you know you're about to get a political answer. So, Russ, let me ask you this question, which is, on the one hand, there's a lot of distraction in our politics today, distracting us from the sort of super important work that you referenced both in our institutions and in collaborative environments. Eileen Cody, who's a giant in health policy, the chair of the House Healthcare Committee, said on our stage a year or two ago that we actually need policy. We need the cudgel of public policy to drive the market forward, and because the market isn't acting fast enough. What do you make of that? I mean, on the one hand, politics can be a distraction from the important work in healthcare. On the other hand, the important work may not be happening enough to those who hold us accountable.
I think economics, and particularly at the state level, are a key issue for our state legislators in balancing the budget and understanding the impacts of those policies on the economics. I'm going to go back to, again, though, what I just talked about earlier. Again, all of us as health providers, we have a tremendous amount of waste that we generate in the work that we do and through our processes. And I think it's up to us to not only develop and deliver a better product, but also I think a product that's more affordable. To the extent that it can reduce the cost of care, I think that opportunity is there. And I think Eileen Cody, who is an awesome leader in healthcare, I think is very mindful of the economics.
Daryll, how about you on this similar question? Can we partner quickly enough? Can we find collaboration quickly enough to keep up with the demands of just pace, you know? And Mike, you might need to bring my microphone down. I think I'm collecting feedback and a little too hot. Daryll, what do you think?
So I think that we're essentially required to move on this as quickly as we can. I think what we're seeing is a convergence of healthcare providers, of the educational system, of the insurance organizations in a way that we're learning to talk with a similar language. So I think it's already underway, but I think we need to accelerate it. And I think we're all responsible. As a higher ed leader, I'm a service-oriented person because you all pay for me to do my job. So I owe each of you a responsibility and an accountability, and I think part of that accountability is to work with folks who are in related organizations and industries.
Mm-hmm. Peter, I know that Medicaid plans, of which obviously Molina is one in the state, you guys have just gone through a spate of reprocurement RFPs from the Healthcare Authority. I think many Medicaid plans feel tired and some level of fatigue from having jumped through all of those procurement hoops. I also know that you've argued that the system isn't working quickly enough. How do we reconcile these two things? This sort of natural fatigue that I think is beyond Medicaid and beyond plans of just trying to do all of this work, and the fact that, I think most people argue pretty confidently that we haven't yet figured this out.
Yeah, I think the I want to go back to where you started this thread. The need for public policy framework to initiate change is required to create an environment of change within that's supportive of a different path forward is as important and as necessary as Russ was just talking about, that each of us individually, as organizations, as providers, as health plans, have a responsibility to lead change as well. I think that, the adage of the only thing that's constant is change, I think is clearly where we are. It's the new normal, and we need to find ways to be resilient within a period of probably a lifetime and a career of change now. I don't think there's no going back to a time when it's not changing.
Yeah. What do you see, Peter, as maybe the next catalyzing event? The ACA, I think, catalyzed efforts, initiatives that were already underway, and certainly if you go back to the mid-2000s, didn't feel like there was a lot of innovation in healthcare in the mid-2000s. Then in this decade, it's been trying to keep up. But things feel like they're slowing down. I mean, I say that and nobody believes that. But it feels like the window of opportunity for significant reform might be closing, and that we're essentially all in an implementation phase rather than an innovation phase. Do you see it that way? And what might be the next catalyzing event?
I actually see it a bit differently. I think we are in a phase of continuous innovation now, because the status quo, or certainly of the past, of the fee-for-service past, and the segmentation of healthcare and segmentation of health, we can't go back. So I believe we are in a continuing period of innovation. I think the next catalyzing event, more likely than not, is that there's a whole host of other publicly funded services, in particular long-term care, long-term support services, that are still outside of this conversation of managed care and whole person health, that have dollar values to them that are as large, or in some cases, many states, in excess of what's spent currently in behavioral health and physical health. So I think the next catalyzing event in the state of Washington, I'm hoping, will be to bring long-term care support services, oral health. There's been a start, but to bring oral health all along as well.
So Russ, what does that challenge look like at the hospital provider view in a rural community? If we're going to do more of these things in the healthcare system, the hospital in Yakima and other rural communities, not that Yakima is that rural, but rural area, is going to have to lead on a lot of this stuff simply because there's not a depth of providers in these spaces that could do it otherwise. How does all that managed care fit in the capacity that you have?
Going a little bit back to your previous question and following up on Peter's comment, what is that next catalyzing event? I think that's actually I think it's a good, interesting, and provocative question. I wonder, though, if that next catalyzing event isn't really for those of us who are largely publicly funded, and I'm guessing many of us in this room are or at least over 50% of that, I wonder if that catalyzing event isn't really putting some incentives in place, significant incentives in place for health systems and managed care providers and health insurance companies to really start working together to provide that whole person health. And that those organizations are taking responsibility and, in essence, at some level of risk to provide that quality care.
When people, Russ, talk about incentives, sometimes legislators hear more money. Does it require more money in healthcare, or do we have enough and we're just spending it poorly?
I think some level of reallocation is potential. There's a huge potential in the reallocation. And as I mentioned earlier, in that fee-for-service sort of environment, there's a tremendous amount of waste that goes on. And so in the essence, if there's reallocation, then I think there's an opportunity to really provide those incentives.
Yeah. Daryll, how do you train students at all levels, medical, physicians and mid-level professionals? How do you train them to be system literate? When you're really trying to train them to be, a care provisioning literate, help them understand basics like anatomy and physiology, but how do you train them to understand you're going into a system that, as Peter has said, is a complex ecosystem with perverse incentives?
So we are facing some real challenges there because there's been more discipline kind of silo in the different professions. And what we're trying to do is we're trying to train in an interprofessional manner so we don't do as much of the skills as we really try to get them to work as teams so that they can do whole person health delivery. But we're also looking at how they understand the context of community health. So one of the ways that we would do that is illustrated with the College of Medicine. The LCNS Floyd College of Medicine is a community health School of Medicine, and there what we're doing is we have 2 years of dwell time for the students here, but then they will go out into the communities to work in clinics. But it is a rapidly changing environment that's very hard to know how to educate the students. One of the things that we haven't perfected is how we do telehealth and telemedicine and how we even educate in those sorts of space where there's going to be more and more demand. How we help students to really understand the needs of patients that are in rural areas and the community health altogether. It's pretty challenging right now, but we see a real change in all of our curricula across nursing, pharmacy, and medicine. There's been a dramatic shift in the way that we do this. We're not sure what all the outcomes will be, but we're making changes very quickly. One thing we're also doing is I think we're listening better. So less and less inward looking and more outward looking and engaging with those in the professions, and so that we can hear from them in real time and iterate that into the curricula and improve the way we're educating our students.
It dawns on me that academic institutions like Washington State University, I'll probably butcher this because I'm just sort of it's just crystallizing for me now as I'm sitting here, but in some ways, if you were to plot the activity of all healthcare on a bell curve, hospitals and health plans exist. In the middle of that bell curve, there's a lot of activity there. And academic institutions are sort of at the start of that activity in the training of the workforce, and they're at the cutting edge front end of that activity in terms of research and true innovation that then gets spun off and integrated. So as the Chancellor, as somebody who thinks at a system level, both for the school and the university and healthcare, being at the sort of beginning end and the front end of that, what do these guys miss? What are they missing? What are they forgetting about as you're sending your students into the healthcare system, into that sort of meat of the bell curve, or as you're sending products and innovation from the front end of that curve into the system, and it gets all chewed up? What do these representatives miss that you all take for granted at the front and back ends of that curve?
Well, the first thing is we need to be more integrated with our partners in the middle of that curve. Yeah. So that's one thing we have to do, but we've joked about it even in the last few hours about how we take these incredibly bright, motivated people and we educate out of them empathy and concern for a broader context. So what we're trying to do is really integrate the experiences and the connectivity with the profession and the communities throughout their educational process. But to jump to this, we're also trying to be more engaged with the broader community, the healthcare providing community. So.
So Peter, there are a range of, Molina's in a number of states, there are a number of regions that have a diversity of hospitals. Washington State, I can't recall the number. Russ, do you remember, is it like 38 hospitals? I can't remember the number of institutions in Washington State, but Peter, what distinguishes a really strong hospital partner for Molina as a health plan versus one that you can't quite figure out the partnership? What are the characteristics that might be replicated from a strong partner that might get spread to academic or other hospital or other provider institutions?
Going back to the beginning of the conversation, which is around partnership, and I'm going to use Russ and the hospital and the system in Yakima that he leads at this point as an example of a hospital that's a tremendous partner for a managed care organization and for the change, in particular with Medicaid. Russ sees himself, and Valley see themselves as the community and not just as a hospital, and has put together an integrated delivery system inclusive of hundreds of providers, not providers that are employed only by the hospital, but are part of the community, and has engaged has been willing to engage in both conversation, but also in a very material relationship with money and incentives that is focused on health outcomes, not on a pay-for-volume, fee-for-service. And it has been very bold and very courageous, I think, on Russ's part. You can talk about it from your perspective. I think in communities where hospitals do not have an opportunity to partner with the community to become much more engaged or don't have a community, in rural areas in particular, the hospitals are terrific, the leadership's terrific, but there isn't the ecosystem around them to be able to put together an integrated system as comprehensive as in Yakima is the challenge, and where I think public policy needs to come in terms of, for example, working with rural areas with a very different funding mechanism, which is one of the things that's on the plate right now.
So that suggests that places like the Central Puget Sound don't have the capacity because of the geography and the population and the definition of community that those are much harder places to find good partners. Is that what you're saying? Yeah, interesting.
And there's a level of income and financing that is required that needs to flow to those rural hospitals so that they can be there. There isn't the opportunity for ongoing, everyday high volume, and we need to find a solution for that.
So Russ, similar question. How do you find and cultivate a good payer partner that will allow you to sort of live and implement the vision of a more value-based, more community accountable kind of healthcare system when going from a traditional fee-for-service volume-centric model to that future state is, essentially risks the whole enterprise if done incorrectly? How do you find those partners? What are the characteristics that you look to cultivate?
Like all interviews, I don't always answer the question directly. And this will be another one of those, but I'll get to it.
Yeah.
I think, Memorial has a history, and it far preceded me, that really attached us to the community and what Peter talked about. And so those partnerships developed almost over 60 years and continued to develop, and it really became part of our culture. And so then it becomes really, as we think about healthcare going forward and what's needed to really serve the community, those partnerships turn out to be more and more critical all the time. In terms of a health plan and working with a health plan, it's about aligned values, quite frankly. It's about really understanding what it takes to really deliver quality care. And as Peter just alluded to, and some of the stuff that we're working with Peter on right now, it is about whole person health care. And we're getting thinking about the entire individual, and the social and the economics and the other parts of the body that we really need to pay attention to, and that's something that a partner like Molina really also values.
Daryll, similar, but the kind of partnerships and collaborations that you explore at Washington State University, they create buildings and they create lines of academic disciplines, and in many cases you're in multiple geographies. You guys have 4 geographies in your school. How do you find those opportunities for collaboration? We all talk about it, but I'm wondering, how do we scale that? And what are the lessons you've learned in trying to find good partners that other people might take and learn from?
Yeah, a lot of people don't realize that across the state here we have more than 100 clinical agreements where we can have our learners actually go into the hospital or into the clinics, and that is where they do a lot of their work throughout their education. So it takes investment, time. We have to go to folks. We have to develop relationship. Some we have decades of relationship with. Others we are just developing those relationships. But it's actually pretty impressive, because what it tells us is that the communities, the clinics, the hospitals, the leadership really does want to work with us to address some of the healthcare needs. So that's a pretty good example, because in our nursing, pharmacy, and medicine programs, in all those programs, there's going to be some dwell time out there with those partners.
Give us a quick rundown, Daryll, of where Wazoo is in terms of students now that are going through its various health profession programs. A little more detail on the 4 communities in which you're training these members, and the progress that has been made over these last few years in sort of quantitative terms.
So while we're the health sciences campus in Spokane, we will have our students doing their 3rd and 4th year clinical activities in Pullman. We'll do it also in Tri-Cities, in Vancouver, and then in Everett. But in addition to that, some know this, but our nursing program is across the state in different places, as is pharmacy, including in Yakima. We have a partner there that is an academic institution, so PNWU, but we also are partnered with clinical partners there. So we radiate from those focal points out in kind of a hub and spoke version of activities. So the students, while they'll be placed there, they will move out into the clinical experiences outside of those domains that I talked about.
And how would you characterize the current Wazoo UW relationship? It's progressed. It's a lot better than it was a few years ago. You can take all the credit. You've only been here a year or so.
So I will credit the leadership that is at Washington State University in UW, that is Kirk Schultz and Anna Marikowski, that I think that they have just decided that we can move forward better together, and we can look for opportunities to collaborate. We can have that healthy competition where that needs to be the case. But here in this environment in Spokane, we have a very active conversation with our UW colleagues, the UW Gonzaga team. So it's a very different environment right now. I think that we're seeing opportunities to work together. So it is a different day. Yeah.
Peter, what is the biggest sort of threat on the horizon that you don't think we as a community, as a healthcare community of practitioners, financiers, and policymakers, what are we really not spending enough attention on as you see it?
I think there's 2 things. First, we're not spending enough attention on sustainability. I think we're very excited about and engaged in the waiver, at least in the Medicaid space right now, and about implementing it. But 5 years is going to pass very quickly, and now we're past due. We need to be thinking about the next step beyond the waiver, beyond the 5 years. So I'm worried about that. And then related to that, I'm worried that because so much is required to focus on implementation of the waiver administratively, that we are not spending as much time truly focusing on health, and we are distracted often by the implementation and the administrative setup that's been required around the waiver, and it becomes distracting to stay very focused on the outcomes, which are a long-term play. Healthcare is much longer than 5 years if we're going to change outcomes.
How is Molina addressing some of these social determinants that speak to health? I think we hold them in relative mainstream regard as being central to addressing health, both in terms of preventing bad health outcomes, but also just helping people when they're trying to recover. But yet they still don't really fit easily in a very clear P&L for most of our healthcare institutions. How is Molina sort of speaking to that?
We are trying to cross the lines in terms of integration. So, for example, behavioral health, we are not carving out Molina's behavioral health services and management. It's all part of our organization internally. We are crossing the lines. We just here in Spokane 2 weeks ago introduced our mobile clinic, which is intended entirely for community outreach and with a particular focus on reaching the homeless populations. And when we are at Blessings Under the Bridge, for example, every Wednesday night here in Spokane, we serve all people. We are not just serving Molina members. We are serving members from all health plans, and we are serving people. There are still people who are uninsured here, and crossing those lines. We are crossing those lines with telemedicine. As Daryll just mentioned, we initiated a number of telemedicine programs, telehealth programs statewide that in the Medicaid space are at no cost to members. And a number of these things at this point we are not individually reimbursed for. We're taking a risk with that, if you will, that it will, from a financial perspective, pay off, just as the mobile clinic does. I can tell you after 2 weeks, which we knew, does not pay off on a day-to-day basis. But if we're investing in reaching people upstream in terms of health, their health needs, and we have community connectors always with the mobile clinic as well, so that it's not just about episodic care, but to connect with them about what their broader social determinants needs are, and connecting them with their primary care physicians, and determining what other supports they may be eligible for in terms of social determinants. That is, we're trying to cross those lines.
Yeah. Russ, I know that hospitals traditionally are not a place where social determinants are addressed, but often they're a place where the symptoms or the impacts are felt from not having addressed them. But in a rural community, I keep calling Yakima rural, but in a community like Yakima, the hospitals, the hospital community they're the big dog in town. So how do you all think of the social determinants in a hospital setting as something that you guys might try to address upstream? Even as Peter said, you may not be directly reimbursed for it.
Yeah, so, there's a saying, be the change. And I don't think the hospital should be the big dog. I think it should be about taking care of our population. Yeah. And in partnership with organizations like Molina and Health Alliance Northwest, through a part of a program that we have at Memorial, we pay huge attention to the social determinants. Good example would be not just a couple summers ago, we had a very hot, dry summer, and we had a number of individuals showing up in our ER dehydrated, right? And so our team of care coordinators, instead of being in the hospital sort of milling around and working on social discharges and those sorts of things, they went out to the homes and delivered water to those individuals because many of them can't get out of their homes to do something so simple as that. So we think it's a huge element of what we're all about. And again, I go back to the partnerships and what Memorial is all about. It really is about taking care of our community, and we can't do it alone, and we shouldn't do it alone. When we chatted ahead of this, you talked to me, Russ, about, speaking of partnerships, your Yakima Memorial's partnership with Virginia Mason, how that came together. You want to maybe just share some of that process?
how did that happen? How did you decide on Virginia Mason? What does that look like?
So as the Affordable Care Act we were all beginning to understand the Affordable Care Act. Our organization, like several organizations around the state and around the country, began to look for affiliations and potential partnerships. And we looked at a number of different opportunities here in the state of Washington. But as we began to really think about the future and what it should really look like, we thought the best thing that we could do was really find a partner that could help us deliver a better product. There are a lot of partnerships that form generally around balance sheets and who has the biggest bank account, but that wasn't our interest. And so I think you all know, or many of us know, that Virginia Mason is well known in this state as well as nationally and in some cases internationally for the quality of care they deliver and the systems that go behind that. And so that was the organization we chose, and we haven't looked back yet.
Yeah. Daryll, what counsel would you offer this group of folks here as they, continue in their own ways at their organizations, within their organizations, external to their organizations? What counsel would you offer them as they try to keep pushing the reform rock up the hill?
So maybe one thing that seems to be a continuous topic and theme for us, but is an awareness about the continuum of the educational process for the professionals and your potential engagement in those processes, including graduate medical education for physicians. In the state of Washington, we're pretty underrepresented in the number of slots and positions that we have, but we're dramatically underrepresented in a number of those positions on the east side of the state. Now, it's a specific example, but what I would suggest is that these are the challenging issues that we will only be able to tackle together, because the federal government has provided funding for this, but we are currently ramping up to educating about 300 physicians here in Spokane. But east of the Cascades, we only have about 150 resident positions for them. And if you just do the simple math in terms of the number that graduate and so on, it's an issue that is really haunting us and we're trying to tackle. So things like that, as you see them come up, please don't think they are somebody else's issue. If you have voice in this and if you can take action, we would encourage you to do so.
Russ, what counsel would you give this room of leaders and executives and policymakers as they continue to wade through health reform?
That's a huge question.
I get to ask it. You get to answer it.
Again, I'm just going to go back to the very beginning for us. As we began to really think through our processes and really talk about quality, safety, service, and access, that really turns out to be the driver for us. And again, once I think if you are performing well as an organization in those particular areas and you're doing the right thing, I guess I'm going to take a leap of faith. I think the right thing will happen.
Mm-hmm. Good. Peter?
I think, again, this may be an old adage, but to keep our eye on health as distinct from health care. And that brings us right then back to the community that all three of us have talked about. The health and health care are two very different things. Mm-hmm. And in a time of change, it's important to always have a constant of some sort, which I believe in this context is absolutely about health and improving health outcomes.
Peter Adler, President of Molina Healthcare Washington, Russ Myers, CEO of Virginia Mason Memorial Hospital in Yakima, and Daryll DeWald, the Chancellor of Wazoo Spokane. Thank you all. Let's give them a round of applause.